Okay. Hi, everyone. We wanted to meet with Dr. Brittany and Dr. Steph, who are chiropractors that specialize in treating pregnant women and postpartum women. So Dr. Michelle and I from Resilient RX are pelvic floor postpartum physical therapists. And so we were going to go through some Q&A questions of common questions that we get about chiropractors and that they get about postpartum physical therapist and pelvic floor physical therapist. So I'll let Dr. Steph and Dr. Brittany go ahead and introduce themselves, and then Dr. Michelle and I will go ahead as well.
Sure. So I am Dr. Brittany. I'm with Peapod Family Chiropractic. We've been in Austin a little over a year. We have an office in Cedar Park, one in South Austin, and then we also do house visits. And Dr. Steph and I actually just met at a networking event, but we realized that we have like the same equipment, the same philosophy on chiropractic. We treat the same population, or we see the same population. And we were like, well, why don't we do more stuff together? So that's how I met her.
That's awesome.
Yep. And I'm Dr. Stephanie. I'm with Homebody Chiropractic. I am a house call chiropractor. I do mobile care exclusively. So I don't have an office. I sometimes meet with patients at Beautiful Beginnings Birth Center. But especially with everything going on with COVID, I am like 99.9% house calls. And I've been in practice for about the same time as Dr. Brittany. And we're hoping to we're planning on partnering and hoping to reach more women that way, or families and kids and all of it. So
awesome.
Cool. I'm Michelle. I'm a pelvic floor physical therapist, and I actually just started working with Mary about a month ago. And
Congrats.
Thank you. And I'm focusing on working with pregnant women and postpartum women, guiding them to get to their fitness goals and to get back with their daily function.
Yeah. And I'm Dr. Mary. I'm a physical therapist and owner of Resilient RX. So Resilient RX is physical therapy, but we offer postpartum pregnancy physical therapy and pelvic floor physical therapy. And then we also offer orthopedics, so with neck pain, shoulder pain, back pain. But Michelle and I, this is something that a niche that we are working with, and we've helped a lot of women achieve goals that they didn't think were possible, because they, like we were just mentioning earlier, a lot of women don't know the resources that they have. And that's really the goal of this call, is to educate women on, hey, these are resources, what feels good for you. And then you can kind of make the decision on, if this is something that you would want to pursue. But either way, the more tools that we give women, the more empowered they can be. So.
Exactly.
absolutely.
Yeah. So we'll ask you guys a question, and then you can come back and ask us, and just kind of go back and forth here. So
Awesome.
Alrighty. So in general, why with postpartum women, can you guys give us an idea of what your treatment would look like for a pregnant woman and then a postpartum woman, and how that would benefit them?
Yeah. So typically, Brittany and I both do like new patient exams. So we want to get to know our patients before we start. So a lot of people think like they can just come and get adjusted and it's like one adjustment and then we're done. But we'll do an exam and talk about everything. Even like we want the entire history of what has happened, like even in childhood, adulthood, and preconception, like fertility issues, all those things. We want to know that. We want to know how much stress the body has been under before, getting pregnant and now being pregnant, all those things. And then we use scans, very non-invasive, safe, easy scans that measure stress on the nervous system, because that's our main goal, is to decrease stress on the spine, which is housing and protecting the nervous system. So that's our main goal, is to care for that, to make sure that you're functioning at optimal levels, at your best, and we believe that brain body communication is what helps you communicate the best, and the spine housing and protecting that system is so important to take care of in order for that function. So once we get all that information, we'll come up with a care plan to get our mamas, our pregnant people, feeling and functioning their best. And I mean, those care plans are super individualized, so it depends on how stressful or how stressed their nervous system is, how stressed their pregnancy is, There's lots of different factors that determine. Generally, like once a week is like the minimum I like to see my pregnant moms. There's so much stress happening on the body, and it's not like, I mean, some people think of stress as such a negative thing, but it's not always negative. It's just that our bodies are changing, their posture is changing.
It's not always emotional either. There's so many different kinds of stress.
Right. Yeah. And, yeah. But emotional is one of them as well, especially during COVID. Right.
Gosh,
Seriously.
yeah.
So
can you imagine being pregnant right now?
crazy times, but
I give props to all the pregnant mamas right now.
Absolutely.
They're doing
really stressful.
Yeah. So I would say, like, very generally, once a week is like the basis until they give birth, and then postpartum care is just as important. I always joke, like, it goes from low back pain to upper back pain. Now holding the baby and like breastfeeding or nursing or, you know, bottle feeding, you know, it's changing diapers, you know, and there's always stress in life, so you always want to get adjusted. You always want to take care of your spine. But yeah, I continue sometimes increase the frequency depending on how the birth went. But once a week is a good wellness adjustment frequency. I know I get adjusted at least once a week. I try to.
Seriously.
If
we go more than a week without seeing each other, we can both like really start to feel it. And then I think the differences between prenatal and postpartum care is a little bit of the intent. So the intent in pregnancy is to prepare the body for delivery, create a balanced pelvis, which creates the biggest pelvic outlet for the baby to come out. One thing that I've had patients tell me is, well, the doctor said that I made a baby that was too big for me. And I'm like, maybe, but more often than not, it has to do with pelvic misalignment, because if your hips are off kilter just a little bit, it takes that perfect circle shape, makes it a little more oblong, and like that does look smaller, right? But it's not always the case. Like I find it really hard to believe that our bodies would make babies too big for us to deliver, because I mean, like, evolutionarily, we want to succeed as a species, so we wouldn't, whatever. So that's one of the main goals biomechanically in pregnancy. And then we use the Webster technique for that. So the Webster technique is a technique specific to pregnant people, and it focuses on that biomechanical balance of the pelvis. So it has to do with making sure that the pelvis is balanced, that little triangle bone that connects the two hip bones together, the sacrum is in a good position. If you've heard of women saying that they have back labor or anything like that, it usually, from our perspective, has to do with the position of the sacrum. There's a lot of nerves that come out of there. So if baby's head is hitting that sacrum in a non-ideal place, it starts to trigger those nerves and cause some things that maybe wouldn't be ideal during the birth process. And then postpartum care, I almost always recommend, even during pregnancy, like postpartum care is something you're really going to want to consider because of all of the things that Dr. Steph said. We go from carrying the baby in here to holding them up here, milk comes in, lots of biomechanical changes in a very short amount of time, probably the most significant that anybody could go through in that amount of time. And we also have that hormone relaxin that's active after we deliver. So relaxin is the thing that allows the pelvis to expand for baby to come through, which is great because without it, we couldn't give birth through the birth canal. But something that I've noticed too is that we tend to carry baby on our non-dominant side, automatically kind of hiking the hip up over there. So that instead of the hips coming back together like this, they come back together like this, which can complicate things from a postpartum healing perspective. And it can also complicate things for future pregnancies.
Yeah, it makes sense. It's those like repeated movements after that we may not even be that aware of. So that makes total sense. And just kind of adding on that, are your adjustments different for, are we talking, the stereotypical thought of a chiropractor is, cracking, popping, things like that. So
yeah, not always.
Yes. So I just wanted to clarify that for, the people listening. So can you give us an idea of what that looks like? And how is that, different than what most people might think right away? Does that make sense?
Totally makes sense. So when there's lots of different ways that we can adjust. So one question that I typically ask people is like, do you not want the cracking and popping? And we have different techniques that we're able to do that with. So one of them is torque release technique. It's entirely an instrument, which actually I think I have right here that I can show you. This guy
Okay.
Looks like a
Um,
stick.
yeah, it looks like a little pogo stick. So that's what we'll call it with the kids. Ours are a little bit different. Goes like this, goes like this. It doesn't really feel like much, but this fires so quickly that it's able to overcome those muscle barriers and still create a change within the nervous system. Kind of anticlimactic though, if you're coming in expecting the cracking and popping.
Yeah.
We stay away from like cracking or popping the pelvis during pregnancy, and we do what's called drop table. So the table will come up, we increase the momentum, and they are laying face down. We have special pillows that the belly goes in so that you're able to lay face down. I joke like, oh, do you just want to like rent the room out at lunch? Because it's one of the only times that pregnant people can be on their bellies. And a lot of the time they're just like, thank you. Like just laying on their belly, they're able to feel better. Exactly.
Feels so good.
And it all is very individualized. So it's based on A, what the person's goals are, B, what the person is comfortable with, and C, what their body is presenting with that day. So that's a question we get a lot with pediatrics too, is like, some people will come in and just be very like, what are you going to do to my baby? Rightfully so. If you've seen YouTube videos of people looking like they're ripping somebody's head off and then you're going to bring your newborn baby to me, like, I totally understand you being a little bit apprehensive to that, but it's very, very gentle. Like there's not a lot of twisting and cracking, and like we meet your tissue where it's at. So nothing should be painful. If it is, then we need to revisit that. And like, yeah, lots of different ways to adjust people. I would say like the cracking is minimal.
Gotcha.
Yeah.
That makes sense.
Yeah, if anyone ever says like I'm scared of the chiropractor or I'm scared of that, it's like you don't have to be, because there's a million different techniques that we can use to adjust you to affect and heal your nervous system without any of that cracks or pops. There's so many gentle techniques. That's just, you know, if someone says they have to be cracked or popped, then, you know, find another chiropractor basically.
Right.
I think that's really important for people to hear though, because, you know, like Dr. Brittany said, you know, people see on YouTube these like, you know,
God.
crazy
I wish people would
rotational
stop videoing
chiropractic.
those, because it makes us look so bad.
It gets views, you know, and yeah. So I think it's great for women to hear that. So
Yeah, absolutely.
cool.
Do you guys have a question for that?
Yes, I do. So I actually got this question 3 times this week alone. It's only Thursday, so there's still time for more. But I've gotten a lot of questions about diastasis recti. Am I pronouncing that correctly?
Yeah.
So basically like the separation that can happen in the rectus abdominis muscles after pregnancy. And a lot of people ask me like, is there anything you can do for that? And the answer is I can help the nerves that innervate those muscles, but sometimes you need a little bit more. So I will typically refer to a pelvic floor PT. So the questions I got specifically are, how do I know if I have it? And if I do have it, like, how can I tell? And what can I do about it? Or like, what would a pelvic floor PT do in those cases?
Yeah. So typically the main complaints I hear with diastasis recti is sometimes our clients, they see a bulge or a doming effect over the midline of their abdomen. So that's usually the first complaint that I hear from people that have a diastasis recti. And then typically to figure that out, if they actually have it, is that when they come and see me, that they start squishing their abdominals, like in the midline, like it feels squishy. Can you please check this? So what I do is that we do a test, and it's by finger width. And then you just have them lie down on the table and then place 2 fingers at the umbilicus or the belly button. And you just have them do like a slight push-up or just have their head and shoulders off the table. And then just a sit-up. Oh, did I say push-up? Oh, I'm sorry.
Oh, you might have said that, but I heard sit-up because I was like, oh, this
Oh, okay.
Oh, she did it. Yeah. I just want to clarify that for everybody.
Yeah. Sorry. I've been trying to work.
You're fine.
But okay. So you do a sit-up on the table, and then you feel for the connective tissue between the rectus abdominis muscles, which are like the 6-pack muscles. So there's a connective tissue and between those 2 muscles, and you feel for that as they do a sit-up. And then you feel for the separation, and then you measure between finger widths how wide the gap is, and you check along the connective tissue, and that connective tissue is called the linea alba. And you know, it's kind of controversial because some people tend to think like, do we need to close the gap or do we need to close it? But it actually turns out that it's not really about closing it. it's more about tensioning that connective tissue through certain exercises.
Yeah, just to kind of add on that, like Michelle was saying, it's measuring above and below the belly button, because we can get diastases above or below or throughout. There's like different ways that we can get it. And so, coning, so like when they feel like they're bulging, they feel like they can't engage their abdominals, that's a common thing. The other thing I would say is they feel like their belly's just bulging. They feel like they feel pregnant. Unfortunately, they get asked if they're pregnant still a lot.
And that's after having the baby.
Yeah, sorry, that's what I'm saying. And so that's actually something commonly they'll come in and be like, I'm so sick of people asking me if I'm pregnant, and I'm 5 years postpartum or whatever. And so those are common things. And so the way that we would work on that is kind of backing up a little bit. When we think of the core muscles, we think of them as like a soda can. And so the top part of the core is going to be our diaphragm. The bottom is going to be our pelvic floor. The front is our transverse abdominis, so the deepest abdominal muscle. And then the back is going to be the deeper, the multifidus, so the deeper muscles along the spine. Okay. So all of these need to be equally working in order to maintain proper core stability. Okay. So if we're getting diastases, we're going to get bulging here. So then it's not uncommon for women then to get pelvic floor dysfunction with that, because if you lose the pressure on the wall here, everything goes down. So then we get pain with sex, we get urinary incontinence, we get urinary urgencies. So a lot of those happen together, if that makes sense. And so restoring activation of that deeper transverse muscle helps to increase the tension between the linea alba, so between those six-pack muscles, to help increase the tension. So what that looks like is, like Michelle was saying, you flex up and you kind of feel the width. But sometimes the main goal is to control the tension. So old school thought is close the gap, close the gap. We're not, as we really start looking more into this, it's more of increase the tension, increase the tension, increase the tension. So yeah, they may have a 2-inch gap or 3 or something along those lines, but if my finger doesn't sink all the way in and I kind of hit a barrier, that's good. And so it's learning how to engage those abdominals so it doesn't just sink all the way in. So yeah, they may have a diastasis, but can we learn how to engage those deeper muscles, so then that way we maintain that soda can stability, so then that way we don't get the bulging. Does that make sense?
Yeah, I really like that analogy.
Yeah. So there's a ton we can do. And I think it's very scary for women, because they're like, oh my God, it looks like an alien coming out of my belly. What's going on? And it's fairly, like once they can really learn to engage those muscles, it makes a big, big difference.
Yeah. I know I get a lot of moms who are like, years postpartum.
Yeah.
And they think it's like too late. So is it ever like too late to get that help?
No. There's so many things.
But I just want to hear from you guys.
Well, just to give you an idea, I had a client that is 5 years postpartum and didn't know pelvic floor physical therapy was a thing, and couldn't engage her core, felt like her abdominals were bulging, things like that. And just learning how to re-engage made a huge difference. Decreased urinary urgency, decreased pain with sex, and then increased her core activation. And so, it would be first learning how to engage the transverse, and then you gradually load the tissues like you would anything else, right? So I'm not going to go and lift, if I haven't done bicep curls, I'm not going to go and lift 50 pounds, because it's just, my tissues can't adapt to that. That's too much. So for instance, we would kind of start, so if we wanted to get them to a plank, right, we wouldn't go straight into a plank. It would be too much. It's just loading the tissues too much. So it might be, we learn how to engage the transverse. Then maybe we do a plank on the wall with a transverse. And then maybe we do it on the table with a transverse. And then we go to the knees, and then maybe a full plank, right? That's just kind of an idea of what it looks like, but it's loading it like you would any other tissue to get the strength, the neuromuscular activation, right? Dusting off those cobwebs, telling those muscles how to fire. And that can make a huge difference. pretty
Yeah.
big.
And just to bounce off of what Mary is saying is that I think there's a misconception when it comes to diastasis because it's such a cosmetic issue a lot of the time. And what women tend to do is that, sucking in the belly because they don't like that, pouchy, bulging look. So they continue to suck in the belly. However, that can also lead to dysfunction as well and make it worse. So it's very important to, educate our patients about the importance of how the core is supposed, or all the muscles of the core are supposed to work together and not just independently. I mean, it's important for them to work independently, but also it's supposed to function together in order to carry out the functions that, we need to do on a day-to-day basis, like lift up our babies and, like carry groceries and all that stuff. So, just sucking in, we think that that's going to make it better, but it could actually make it worse because like what Mary described with the soda can analogy of the core is that, if one thing is compromised and then you're focusing on one thing, so much like the changes in pressure of the soda can, they're just going to keep going. It's just going to force it down. And that's going to compromise the pelvic floor in the long run. And that can create dysfunctions like incontinence, pain with sex even, maybe even a prolapse. So it's very important to be careful about, thinking about the exercises that you have to do in order to decrease the diastasis.
Kind of going off of that, I have a lot of people in my life that have had kids that'll just be talking to me as friends, and then, or like patients. And then I'll say like, have you considered a pelvic floor physical therapist? And they'll say, what's that? And then I kind of have to take a step back because with Dr. Steph and I seeing pregnant people for so long, we kind of forget that it's not in the common knowledge of pelvic or of the public, and having to explain like, what is a pelvic floor physical therapist? And I'm also a big fan of like, well, once postpartum, always postpartum. So yeah, even if you had a kid 20 years ago, you're still postpartum. This is after you delivered a baby. So could one of you go over really briefly, just like if you were to explain your profession to somebody in 2 minutes or whatever, what should we be telling people a pelvic floor physical therapist does?
Right. So a pelvic floor physical therapist. So first of all, any pregnant woman or postpartum mom that is, they've gone through labor and delivery, it's going to have a huge impact on their pelvic floor muscle function. So a pelvic floor physical therapist is going to do a careful evaluation of the entire body and not just solely look at the pelvic floor muscles, and carefully assess the integrity of the muscles, the strength of the muscles, the coordination, in order to see if the pelvic floor is working optimally and with the rest of the body. Does that make sense?
Totally.
Mary, do you want to add on to that?
Yeah, I would say that, and then in addition, when we assess those pelvic floor muscles, there is a internal pelvic floor assessment if clients are comfortable with that, and then that's where we can assess the strength and mobility inside the 3 different layers of the pelvic floor to determine why they're having pain with sex. Are they even engaging their pelvic floor muscles correctly? Things like that. So overall, I would say, we specialize in, pelvic floor dysfunctions that to either help improve the strength of the pelvic floor, help improve the mobility, and then help it coordinate with the rest of the body because, it's not just this separate entity, it's everything around it. So that would be kind of the gist of it. Again, just in summary. Does that, is that something that you guys were kind of describing to people in that way, or? So I was just looking up here. I wanted to pull up I'm pulling up my video here. So that way you guys can kind of see what I'm talking about with the diastases. I'm just going to pull up a picture and then a video here. It's actually taking a second, but if you guys want to go ahead and you can go through another question, but I think it'll be really cool for you guys to kind of see the picture of the diastases and then how the pelvic floor and the diaphragm work together. And when you kind of see it, it's really neat how it works together. But I think I'm going to actually, here we go. I'm going to
pull the soda can analogy like that. showing that.
I'm going to show the different pictures of the diastasis. So I'm going to pull this up here. I'm going to share it with you guys. Can you see it?
Yes.
Oh yeah.
Yeah, so I really like this
A good picture.
analogy, right? So we can get it around the belly button, we can get it below the belly button, we can get it the full length, and we can get it above. So when we do that testing, we're going to be doing it in between these areas, right? And then seeing if we're getting a large gap, are we sinking down into the abdomen? Those are things that we're looking for.
Right.
So, just
and also
kind of share that.
like for diastasis, sometimes people have like the slightest separation. So it's important to know, I believe the diastasis, it's anything more than 2-finger width. That's what we learned. Mary, you think that's about
I think it's that, and it's also the tension. So in my experience, they can maybe have like less than 2, but if my finger sinks all the way down and they feel like they can't engage the core, in my professional opinion, that's a different form of it as well.
Right.
If that, just to kind of think of it in a different way.
Mm-hmm.
So one question I get also that's super common, kind of related to diastasis and then kind of everything with pelvic floor therapy is how soon postpartum or even while they're still pregnant, like what do you recommend where moms start seeing a pelvic floor therapist? Because I recommend it to every one of my pregnant patients that a pelvic floor therapist is good to just be evaluated, because like my mom is 70 and she's seeing a pelvic floor therapist right now, so that's pretty cool. She didn't even know that she needed, she didn't know, but somebody recommended it to her for, I can't remember what issue started it, but yeah, so I mean, but what is the ideal time that a pregnant person or postpartum person should reach out to see or be evaluated, or what are the common, I guess I get like, why would I go see a pelvic floor therapist? Like, how do I know I'm like, well, you just gave birth, like, so that's how you know, but like, how would they like concretely know that they or when and how, I guess?
Yeah, so usually if they're having symptoms during pregnancy, like back pain, incontinence, things like that,
Okay.
they can come in. But I think in general, it's always good to maybe have one before birth and then after birth, just for like a ton of education and just knowing, hey, this is how birth is going to be. This is what to look for after. And then that way, when these things happen, it's not scary and it's not, oh my gosh, my pelvic organs are falling down. So generally though, when to really see someone is before pregnancy, because what we work on is focusing on down training the pelvis. And so what that means is, so many women are told do Kegels, Kegels, Kegels before pregnancy. So if we break that down, why do we want to tighten muscles that are about to push a baby out? Right. So we need to kind of change that mindset and talk about how to down train those muscles, how to relax those muscles so we can push baby out, talking about different birthing positions. And because I think a lot of women just think that laying on your back and pushing that way is the only way, when, there's so many different birthing positions that can make it so much more efficient, right? When we have a bowel movement, we don't lay on our backs,
Exactly what I say to people. I think Hollywood ruined the idea of pregnancy for people. They just picture you on your back like, dad, that's tummy. And it's like, yeah, have you ever tried to take a poop laying down? Like, I don't think it would be very advantageous, but
yeah, you want gravity helping you push it down, right?
You want your pelvis to be open, not closed down from laying.
With that sacrum again, like coming up.
Exactly. Yeah.
Exactly.
That.
Allow the sacrum to move backwards out of the way, but you're pushing it forward, and like, it's so backwards. It's crazy.
Well, and then it's also too, because like, but if you end up having to have, like, if you choose to have an epidural, you're limited in the positions, right? Because you can't feel your legs, so it could be more dangerous. But that's when positioning, maybe talking to them, laying on your side, right, instead of having the pressure on the pelvis, things like that. So educating them on that, and then what to look for after pregnancy, and then postpartum would be typically, we talked about part of the pelvic floor assessment can be an intravaginal assessment. It doesn't have to be. I always preface it like that because it can be scary for some people, and it's really just assessing the tissues in the pelvic floor, right? And then are they actually contracting? And but then we can also do everything externally. So postpartum, they can come whenever they feel comfortable. We can't necessarily do an internal vaginal assessment until standard of care is really about 6 weeks, unless the OB writes us a letter or a message saying, hey, this is cool. But, we just want to respect that timeline and allow healing too. If they're still having healing stitches, we may not do an internal assessment or, things like that. But I would say for sure, if they've had a C-section, coming in and learning how to re-engaging those abdominals, moving the C-section scar, because if that C-section scar, a lot of times that can cause urinary urgency, because if you think about how they have to cut through to get to the uterus, what can happen is the bladder can get bound, the scar tissue can kind of bind to the bladder, and then we don't get full expansion and contraction of it. So then we get urinary urgencies because it's like, I gotta pee because that bladder's not filling and then relaxing. So, that, I feel like that's always a piece where like women's mind are like, they're blown because it's just, we think about it like scar tissue and it's going to bind to visceral organs, we just don't think of it normally like that. We think of it maybe if we had a shoulder surgery or something like that.
Yeah.
And a very common thing that I hear in postpartum is that I completely lost control of my muscles everywhere.
Yeah.
So you have to retrain. It's very important to retrain those muscles with the functions that they're doing. Especially if they just had a baby and they're getting used to their new body. Sometimes it's like really hard to just try to get control of your muscles and even just like feel for where everything is. And now they're inundated with a new baby and, the last thing they think about is themselves. And then down the road, they're like, I've lost all control. I'm leaking. I'm feeling pain. Like, what do I do? So, as a pelvic floor physical therapist, we do a lot of education and training on just like how to use their new bodies now and to empower themselves so they, don't have to, run and leak urine. So they don't have to have pain with sex because they think it's normal. When this is something that could be fixed.
Well, nobody's talking about that either. I think there's this expectation for you to just, be pregnant, you had a baby, bounce right back. And it's like your body is different postpartum. It's the same furniture, but it's moved around and you have to know like how to access all of that furniture. And I think there's a lot of pressure to like get your pre-baby body back, which is, I think that's incorrect thinking. And I think women feel some type of way about it, just like, what's wrong with me that I can't go back to normal? And there isn't enough focus on the postpartum side of things, especially in Western medicine or in the culture that we live in.
Right? No, for sure. And unfortunately, I think social media has really caused a lot of that, because women might be like, well, I don't look like that. And it's like, you don't know if that picture's photoshopped. Like, you don't know the full situation.
Might have been taken before pregnancy and they're lying to you. Who knows?
Exactly. And so, and I'm starting to see more women just be like, hey, real life, this is my body. This is what I look like. And I think it's really good for women to feel that way because, culturally, we've already kind of been set up to have body image issues. And then you add on pregnancy and then Instagram models and all this stuff. And it's like, listen, like, great if you can, great if you can, potentially look that way, but that's not reality. Reality is, your body's changed. You pushed a human out of your vagina. Like, nothing, your body won't be the same. It's going to be different, but in a good way, in a beautiful way, because now you're a mom. And because you're a mom, that doesn't mean you can't have, sex without, like, you can have sex. You can still feel sexy. You can still engage your abdominals and still work out. I think that's a big thing too, is women feel like, I'm supposed to have pain with sex. I'm not supposed to have sex. I'm supposed to pee my pants. I'm a mom. It's like, having a child doesn't have to be this like life's body sacrificing thing. I mean, yes, it is, but know that we have all of these tools to help with that and to ease the mom guilt and, get yourself back, because it's important to get your own identity back as well, because once you have that, then you can help the child and you can help everybody around you as well. And so, there's a whole,
you can't pour from an empty glass.
What's that? Yes.
You can't pour from an empty glass.
No, it's so awesome to talk about all this. And I hope a lot of people see this, because I talk to so many moms that like everything once the baby comes, it's about the baby. It's about the baby. It's about the baby. And you're selfish if you're worried about yourself. And
Mom
like,
shaming is a real thing too, and that's
Mom
not cool.
shaming.
you
Yeah.
have to take care of yourself though, because then, you know, if you take care of yourself, you can be the best mother. And, you know, it's so sad that when these women, you know, they talk about like, oh yeah, I pee when I sneeze, like all these things, but I'm just a mom. Like that's what I had a baby. So now I pee when I sneeze. I can't work out. I can't do a jumpy jack, jump ropes. Nope. Like, and they just feel like they are these less functioning beings now because they are sacrificing and giving everything to their child, which is wonderful. You know, it's a great part of motherhood, but it's okay to take care of yourself. And I've told moms where I'm like, sometimes it's selfish to not be selfish, because if you don't take care of yourself, you're going to break down and you're not going to be able to take care of your family. And so I've had lots of, because a lot of times, like I know Brittany probably here's the same thing. Moms come to us like after they're broken, basically, and we pick up the pieces. And
and on that note, we get this question a lot too, or like when I'm just out talking with other providers, like, well, when does somebody know when they should see a chiropractor if they're pregnant, before they're pregnant, all of that. And I think, like to tie into that, like it would be great if we could see you before you were broken. And you don't, like Dr. Steph and I's practice models are that of wellness. Like the goal is that we don't have to wait until you're already broken to try and pick up the pieces. There are a lot of people that choose to come to us in pregnancy right when they find out, just to set up all of those dominoes in the way that they are supposed to be. So you don't have to be symptomatic. You don't have to be in pain to get care during pregnancy. I just had a mom who decided to start wellness care when she was about halfway through her pregnancy. She was like, I feel fine. I just want to prepare my body for delivery. And she had a very boring, straightforward birth, which is what you want to hear as a provider. Like, what happened during birth? It was super boring. Baby's here. Great. Like, you don't have any problems. That's amazing. Right. So I think there is also this feeling of like, well, I don't need a chiropractor. It's like, well, how do you know? How do you know if your kidneys are functioning right now? Like, how well is that signal between your central nervous system, your brain and spinal cord, and all of your organs? Do you know how well that connection is between your brain and your uterus? And those are the things that we're able to test with the scans. And this is anecdotal, but I was talking with a doula who delivered over 100 babies.
Wow.
And she was like, you know, just in my experience, I noticed that those that receive chiropractic care, not for any particular reason, but just to like prepare everything, it tends to be those like boring births. Like we don't have anything written up or any research I can show you on that, but like in her experience, that's something that she's seen.
Mm-hmm. And in like 6 years in practice, like I've taken care of, I mean, hundreds of pregnant moms, pregnant people. And the moms that come to me earlier in pregnancy and see me regularly, like their birth almost always, unless there's some like, you know, risk factor or something that happens, sometimes like blood pressure, breech baby that just won't turn. But they almost always have the birth, like Brittany said, like boring, like everything goes really well, boring and or exciting, you know, like, but like I've had 4 moms in the past 2 weeks, less than 2 weeks, give birth. And all 4 of them had, they were under care from like 20 something weeks or before, saw me regularly. All 4 of them had fantastic births, which is awesome to hear. And I think 3 out of 4 had no tearing, which is also awesome. You know, that shows that the baby was in a great position. Mom did awesome, listened to her body. Like, so it's so exciting to see that. And it's like, yes, like I know chiropractic works because you saw me. And then the mom came to me at like 38 weeks in severe pain with a breech baby or something. Like, you know, it does help, and sometimes we have a lot of success, and sometimes it's like, you know, I can only fix.
Like we're trying to combat the changes that your body are undergoing, and they're super, like the changes are abundant, especially towards the end. And it's like, I mean, at this point, there's only so much we can do. On the tearing note, talk to us about tearing. What are you guys able to do for that?
Yeah. So that's when we kind of talked about if you come before, you know, like you said,
prevention is the name of the game, but if it's reactive.
Well, for preventative, it can be, you know, it can be, like I said, relaxing those muscles, calming down that, like getting the pelvic floor muscles to relax, picturing kind of baby coming down and out, loosening up the muscles around the pelvis, around the hips. And then, you know, sometimes if the client is okay with it and the OB is okay with it, we might suggest a perineal massage, so just kind of stretching those tissues just to get them used to stretching, because they're about to be stretched real intensely in a few weeks, right? And so usually it's kind of starting that a few weeks before birth as well. Like I said, I usually just have them just double check with their OB, since it is going intravaginally, just, you know, to the first layer and just stretching. So there's that. And then if there is tearing afterwards, we can have different degrees of tearing. And then sometimes we'll even see, rarely, they don't happen as often, but in episiotomy, which is when they cut through the muscles surgically versus natural tearing. And so Michelle can kind of add on to this as well, but it's, well, first, you know, allowing the tearing to heal. And then we need to get the scar moving, because when that binds down, it limits the full contraction, relaxation of those pelvic floor muscles, right? So we can get painless sex, because maybe if the tearing's like right at the opening and then initial penetration happens and it's like, wow, that doesn't feel good. So we might get tightness, you know, on the initial 2 layers of the pelvic floor. Usually when those get tight, that can cause pain with initial penetration. And then if there's tearing kind of further up, just depending on the person, you know, you might have pain with deeper penetration. And so it would be getting the scars moving, getting the muscles to activate afterwards, or getting them to loosen up because they might be tight. So it just depends on the state of the tissues. But Michelle can kind of add more onto that.
Right. So manual therapy is very important in that sense, because you don't want to start doing Kegels if you had a tear, because like what Mary said, there could be scar tissue or adhesions preventing from the pelvic floor muscles to fully get that full contraction and full relaxation. So, you know, it's important to focus on that, educate our patients to do some perineal massage if it's safe. Sometimes we even have their partners come in and we teach them how to do it. So that's also builds some intimacy postpartum, which is also really nice. And then once they learn how to do that, then we start to train and teach how to fully contract and relax. Then they say, okay, I have controlled my muscles now, and then work with that. And then not even just pain with sex, sometimes they can get incontinence from it, even fecal incontinence if there's a big tear. So those are some things to consider.
Yeah.
It's good to know that there's options, because again, like sometimes I'll just be talking with my friends and they'll be like, oh yeah, I had crazy bad tearing, and like, it is what it is. And I'm like, but it's not is what it is. Like, there are things that you can do about it. And this just goes back to the whole, like, just being like, oh, you had a baby, whatever. But like, I think that the solutions postpartum for the things that can happen during pregnancy, birth, and delivery should be talked about, because like, there are options that like a lot of people don't know that there is anything you can do for tearing. So that's great.
Well, I mean, think about your quad. If your thigh muscle was cut into, right?
And yeah.
We're not going to just be like, meh, it's fine, just get it stitched.
It is what it is.
Just gonna walk a mile.
Yeah, whatever. Which just, we like forget that there's like this whole area that we think it's only for poop, pee, and sex. And it's like, it's a major stabilizer of everything.
Totally.
Abdominally.
Important.
Yeah.
Well,
So-
when Dr. Steph and I adjust, like we both typically start at the pelvis, make sure that's balanced first, and then work our way up, because it is like, it's the center of everything. And like, even a lot of like knee problem, like people will be like, I'm having this knee problem. Like, well, let's look at your pelvis. And like, it's like an adaptation to that misaligned pelvis.
Yeah.
For sure. And then like you were saying earlier, the relaxin, you know, we get some SI dysfunctions, you know, I don't see them as often unless people are pregnant or postpartum or they've had a traumatic injury. But in general, yeah, that's that, you know, the pelvis is changing. We're getting different movements, and typically that SI joint is pretty darn stable. But then when you start adding relaxin and then the baby, you're going to get kind of shifting and all this extra movement in the pelvis, which can then cause pain, dysfunction, all of the above, which is, you know, what you were saying before is, you know, yeah, that can alter potentially the positioning of the opening for the baby to come out.
Definitely. I think we're coming up on almost an hour here, but I think a good way to end would be talking about how physical therapists, especially pelvic floor PTs and chiropractors, can work together. Because I get that question a lot, like, well, I'm already seeing a chiropractor, should I see a PT also? And I'm like, yes, do all the things. Like, you can never have too many providers as a part of your care team that want the best for you. So have you guys worked with chiropractors in the past, and like, what do you guys typically see from that?
So I have, in my past, so I used to work at a clinic in New York City. I actually recently moved here 2 months ago.
Welcome.
Yeah, thank you. So a lot of my past patients, they kind of go like the positioning of the baby. And I actually want to, you mentioned this, like when it's in the breech position. So sometimes like the first thing that comes to mind is like a chiropractor, and if they should, because you guys do some work in, you know, changing the position of the baby. So that's one way that, you know I can refer to you guys. And if there are other ways, like, please discuss.
Yeah.
Yeah,
Well, one
totally.
thing with the breech thing, we always have to like preface, like, we don't turn babies.
Okay.
Chiropractors do not
That's
turn
good to
babies. So don't ever say like, hey, go to the chiropractor, she'll turn your baby. The thing is, the way we can help, especially with the Webster, that technique that we talked about, is that we affect that pelvic bowl, right? So if the joints aren't moving correctly and the whole, the outlet is changed, that can affect the baby's position. But also there are ligaments that attach from the sacrum to the uterus and from the pubic symphysis to the uterus. So
Here's
again,
the thing for it.
is shifted.
It's on there.
Oh yeah, right there. So if the pelvis is shifted or not misaligned, not moving correctly, it'll tug on those ligaments that have smooth muscle in them, so they can actually contract. And that's when women talk about having that belly pain, like down at the bottom of their belly, the right or left side, or sometimes both. Those sharp pains, that's those ligaments like contracting, because smooth muscle contractions don't feel good, right? Because the uterus contraction doesn't really feel good. And that's smooth muscle. So the way we affect it is to make sure that the pelvis is moving correctly, and then we release those ligaments, those smooth muscle in the ligaments, release the tension there, and just kind of balance the pelvis and the surrounding tissues. And what's so cool is that the babies have this amazing, like, innate, like, intelligence, right? They're growing themselves. They know exactly what position is best for them, what's the safest, best position for them at that time with their environment. So we can change the biomechanical environment, and then the baby will be like, okay, I have room now. Well, now this is the best position for me. It's not about us being like, we're going to turn the baby. We're like, we're creating the environment for the baby to be in the best position. So if the reason that the baby is in a breech or transverse or asynclitic position is because the pelvis is shifted and those ligaments are putting tension on the uterus, then we can affect that. Sometimes I've had babies that don't turn. That does happen. We're not 100% effective. We're like 80% effective, or sometimes more.
Totally. Because sometimes there's something else going on.
Yeah,
Right.
nothing's ever guaranteed, right? You
Right.
can just set up, do the appropriate things to set up for the environment. If the baby doesn't turn, the baby doesn't turn.
Yes,
But,
exactly.
but what you're saying is, yeah, setting up the pelvis, so then that way we potentially decrease potential risks of breach.
Exactly.
That makes sense. And then Randy, kind of add on, I've worked with chiropractors a lot, and really a lot of times it's, I think the most important thing is like the communication between the two providers too. And just that,
Yeah.
hey, I worked on this, I'm starting to see some of this stuff. Can you guys, I know this is more your focus. I just wanted to say like, hey, this is what I'm seeing, and, do with this information with what works best with you professionally and, in your experience, and then, vice versa. So I think the most important thing is, recognizing both of our strengths, and then either, co-referring or talking to each other about, hey, these are some things that I'm thinking, and then how we can help the client together. And our clients love that, because then they feel like they're really taken care of, and we're working together as a team versus like all these separate people.
Totally.
Yeah.
Something that I noticed, just like in general, the PTs that I tend to work with and the clients that I have that see a pelvic floor PT and myself, what chiropractic is, and like a lot of people think it's just like back pain, but your spine lives in your back, which is why that's the place that we go to. So we're mainly focused on making sure that the brain and the body can communicate with 100% nerve flow, right? So I really like seeing clients that are also seeing a pelvic floor PT because you guys are working on what the muscles are actually doing, whereas we're working on what the nerves that are talking to those muscles. So I find that those clients get the best results the most quickly because we're working at it from both ends. Like you guys are kind of working on like muscles and telling your brain to turn those muscles on. And if we're providing the nerve flow to be able to create those connections, and the connections usually happen a lot faster. I notice it with occupational therapy and us with kids as well. They tend to make the connections more quickly and more effectively when we're getting at it from every angle possible.
Yeah, definitely. Like kids with torticollis too, like when they get adjusted and then go see a PT, like they get that nerve flow back to those muscles and like get that realignment, and then they get, you know, relearning how to use it and like stabilizing those muscles, and being like the function of both chiropractic and PT together has always been awesome in my experience.
Yeah.
So all of those conditions.
Yeah, I think, you know, and like we were saying before, just all of us kind of working together and recognizing each other's strengths and, you know, hey, you know, this is what I'm seeing, this is, you know, kind of going back and forth. And, you know, with that too, is just, you know, just solidifies that, you know, great quality care, because we're all, you know, trying to help these women have better births, have better postpartum pregnancy, postpartum phases and things like that. So
Absolutely.
Cool.
And speaking of house calls, I've got one of those to do, but like I have so many people that I want to send this to. So can I get the recording at the end? Like, this is so helpful.
Yeah,
great.
I will send it to you. And just kind of a side note, Michelle's doing a workshop. I think, is it next weekend, Michelle?
The 22nd. I think it's next week, not this weekend, the following weekend.
Yeah, on pain with sex postpartum. And so we can send you guys that link too, if you're interested in that, because we get
please
a lot of questions. So cool. Well, so nice meeting with you
so
guys.
Nice to meet you guys. Sorry to run and like cut you off.
No, I have a client.
Perfect.
All right. Bye.
Bye. Thank you so much.